Hi, everybody. Welcome. Welcome. Wow, this is a really hot microphone. So welcome to the session on partnerships to improve the health of residents in public housing. If you want to come closer, that would be great, but if you feel fine back there, stay back there. We want you to stay. That's the goal. Our presenters would love for this to be an open dialogue, so if you have really pressing questions, feel free to raise your hand, and if they're going to address that issue a little bit further, they'll say, just give me a couple of seconds, we'll get to that, or else they'll be taking questions as well at the end. Additionally, Dr. Leon is here with our pre and post tests. He's distributing them right at the moment. Additionally, there are CEUs for those social workers and nurses that are interested in obtaining those. So if you are interested in obtaining those, please let him know when he comes by as well. So welcome again to today's session. I have the privilege of introducing our distinguished panel members, and I want to start with Mary Walsh, who's a Senior Program Manager for the National Council on Aging Center for Healthy Aging. She provides technical assistance, guidance, and program management to state government agencies and community-based providers that are implementing evidence-based health promotion programs, including Stanford University's Chronic Disease Self-Management Program. Mary graduated from Case Western University and has a master's degree in education from Northeastern University. So it's a pleasure to introduce Mary.
Well, thank you. It's nice to be here with all of you today, and it's always great to be back in Colorado. It's a state that I really enjoy. Today we're going to be talking about chronic conditions, the impact on families, on the person who has the chronic condition, and on the staff of your organizations. We're also specifically going to be talking about the Chronic Disease Self-Management Program, and then we're going to also talk about some other evidence-based programs for older adults. We're going to share some of the work that's going on with federally qualified health centers and medical homes to address self-management, and we're going to talk about the evidence-based programs that are offered in public housing for people not only who are older, but also those with disabilities. I'd like to start by saying that beginning in January of 2011, 10,000 people a day turned 65 and older, or turned 65. And that's going to continue until 2030. So you can imagine the number of people that are turning older, and along with that comes a number of challenges and also opportunities. More than 6 of 10 of those people will be managing more than one chronic condition. 1 out of 4 will be living with diabetes. 1 out of 3 will be considered obese. And 1 out of 2 will have arthritis. Oops, I'm sorry, I didn't mean to do that. I'm changing our slide. There are a number of federal agencies that have been very involved in this issue over the past several years. One of those is the Administration for Community Living, the Administration on Aging. And they've supported programs so that up to 47 states could address the issues of chronic conditions by instituting evidence-based programs within their state. Right now, they have a grant program for 22 states who are implementing the Chronic Disease Self-Management Program. They're expanding it, and they're bringing it into different areas. So today we're going to talk, as I said, about evidence-based programs. Some of you probably know what they are, but evidence-based programs are proven to work if they're administered with fidelity. So if the programs are administered the way they're intended to be administered, they do work. They do help people with chronic conditions. They're interventions that are based on evidence that's been generated by scientific studies that are published in peer-reviewed journals. They translate some tested programs into effective community programs. The Chronic Disease Self-Management Program, which we're going to concentrate on today, is one of those programs. It was developed at Stanford University about 20 years ago, almost 30 years ago, actually. And it's a peer-led class, so that a person with the chronic condition is the one that's helping other people with chronic condition to learn self-management skills and how to manage their conditions day to day. Those who are involved in the programs learn skills for exercise and nutrition, medication usage, stress management, communication with their physician and other healthcare providers, and dealing with emotions and depression. Here in Colorado, there's been some excellent work done over the past several years around evidence-based programs and the Chronic Disease Self-Management Program. The Colorado Department of Human Services and the Colorado Department of Public Health and Environment have been working with community-based organizations. We're going to be hearing from some of those partners today. And first, we're going to hear from Ada Schwer from Volunteers for America, and she'll be talking about programs that they've been doing. And then Lynnzy McIntosh and Renee Karl will be talking about programs with federally qualified health centers and medical homes.
That's okay. Let me just tell you a little bit more about Ada as we begin today. She is a program manager and fitness professional for Healthy Aging Department of Volunteers of America, Colorado branch. Ada attended her Bachelor's of Science degree in dietetics from Iowa State University and received a Master's in Public Administration from Texas A&M University, Corpus Christi. She is a master trainer for the Arthritis Foundation and a certified personal trainer through the National Academy of Sports Medicine. Ada.
It's okay. Good morning. I have a really loud voice. I'm going to try not to be too forceful in this microphone. That's fine. So there's a couple things I want to talk about this morning, and the first one is I just want to mention the organization that I work with, and that is Volunteers of America right here in Denver. And a lot of people don't really know what all the services that we have that are provided to the community. We have housing for seniors, we have housing for women, we have shelters, at-risk youth centers. Most people know us for Meals on Wheels. There's a lot of different things that we do. Handyman program where we have some staff members and volunteers that go into the homes of seniors and put in railings for the shower, like things to make their homes safe. And also we have a healthy aging department, and that's where I come in. And we have been offering evidence-based programs for about 6 years now. And I just want to do a quick run through of some of them that are up on the, this one is the Arthritis Foundation Exercise Program. This is group exercise for those who do have arthritis. All of our clients, obviously, you don't have to have arthritis, but we do serve those who are over the age of 60. And if they have any kind of disability, this class is wonderful for them to help them move better, their activities of daily living, help improve those. The second one is the CDSMP, Chronic Disease Self-Management, as Lynnzy will talk a lot more about as well. An amazing program, just teaching participants how to manage their chronic conditions and how to take control and do the self-management. Healthy Moves for Aging Well. This is kind of really just special to me. We get to go into the homes of homebound individuals, teach them how to exercise. A lot of times they're our Meals on Wheels client and they're very weak, so we get to go in, give them weights, show them how to do exercises on their own, and also they get free consultations with a registered dietitian. We have 2 dietitians on staff, so that is a great benefit to that program. And all of our programs are free. I don't know if I've said that. We do have grants. And if you're over the age of 60, they're free. For some of our programs, there's a small fee if you're under the age of 60. So just putting that out there. And Matter of Balance is the evidence-based fall prevention program. We put this on everywhere. We go to senior centers, housing authorities, any kind of senior community, recreation centers. We've been in hospitals. So we implement that program all over the place throughout the Denver metro. And lastly is the Steps to Healthier Aging class, 1 and 2. Steps 1 is nutrition education, more on a, I don't want to say a surfacey level, but more easier topics for participants to comprehend, talking about sodium and how does that affect hypertension. So our dietitians try and make it applicable when it comes to their diet, especially with our low-income population. You know, they may not have the funds to buy organic foods or buy the best quality this and that, so they teach them how to make real applicable choices when they go to the store and things like that. And the other half of Steps is the exercise component, and we do group exercise within the Steps to Healthier Aging program. So I wanted to talk a little bit about what we see in senior communities and senior housing communities. What do participants look like? And it's hard because we're the instructors. We're going in and we maybe see a percentage of these housing communities. We don't get to see the whole shebang. So mostly what we see are low-income single women, and a lot of them have a chronic condition, one or more chronic conditions. I think, Mayor, you had mentioned that. Very common, and it's probably going to become more common as the baby boomers continue to turn 65. And we see a lot of people struggling with just some daily activities, being able to go to the grocery store, being able to do their laundry, just kind of like those integral activities of daily living. So we see a lot of struggling just with physical limitations, disabilities, like I said, the chronic conditions. So we get to see a lot of that. And very common is the arthritis, hypertension issues, diabetes, obesity, overweight. A lot of that is very common from our participants. So we come in, and I want to tell you a little bit about the impact of our programs. So what is really great is, especially with the Chronic Disease Self-Management Program, we don't necessarily, Volunteers of America doesn't collect hard data like for pre and post tests, and maybe Lynnzy can talk through that after why we don't anymore. But we get phone calls all the time and letters, and if we ever revisit a site and bring back another program, we have participants always telling us, wow, the deep breathing exercises, the action planning, we're still doing action plans every week, trying to make better, healthier choices, better nutrition choices. And it's just wonderful to hear that just along the years. We hear it all the time, and it's just kind of refreshing knowing that they did grasp concepts and really took this to heart to make a change in their life. I will go through a few pictures here. This is just a program at one of our Volunteers of America congregate meal sites downtown Denver, and we implemented the Arthritis Foundation exercise program, and they just had a ball. Oh my gosh, it was so fun. It's a 6-week program, and after we finished the program, you see Mr. and Mrs. Chen on my left and right, and they took over, and I believe they're still continuing to do the exercise program at their facility for their friends and residents that live there. This is a recent class. Molly, way in the back, she's our community nutritionist, and she's a registered dietitian. So we're going through 12 weeks of a lot of nutrition topics and teaching them how to take better care of themselves, especially with making healthier food decisions, and how do foods affect them, the sugar, the fats, the cholesterol, how is that affecting their bodies. This is a few clients from the Healthy Moves program, and this is, like I said, we get to go into the homes and teach them how to exercise, and they do get free nutrition consultations. We see some amazing stories, and I would be lying if I said everybody is impacted, every single person has a great result. That's not the case. That's not the reality of these programs. But we do have very great statistics, and if you ever want to talk statistics with me, we can talk after. But just for an example, we have a 94-year-old woman who just got out. She had a hip replacement, had her rehab, and then she couldn't afford to go to PT or get any follow-up care with that. So her daughter called our department, and I went and saw her, worked with her for 3 months, and anyway, she ended up getting a lot, and she ended up going to the Boulder Dinner Theater with her family and had the best time of her life, and it was just great that she could get out of the house and actually go do something. So this is a really fun and amazing program as well. A lot of times we've had coordinators or activity coordinators, service coordinators call us and say, could you implement a program if we have all monolingual Spanish residents? And I'm not fluent in Spanish, I know a little bit, or Russian in this case. This is a Russian group. So we kind of work with the coordinators, maybe Matter of Balance or the Chronic Disease Self-Management Program. I couldn't speak in Russian. I don't know if there's instructors that speak in Russian here in Denver. However, the Arthritis Foundation Program, which is a lot of exercise and just a little bit of education, let's go for it. So Elena, the coordinator, translated for me, and they had great results with this program. They started feeling better, and a lot of them are still exercising to this day. So that was a really cool experience. And this was a Chronic Disease Self-Management Program up in Brighton at the Eagleview Adult Center. And that went very well. As you may have seen, we have a lot of women in our programs. We always try and get the men out. There is some reluctancy, and I'll talk about that in a minute, just how do we get participants in these programs. Does anyone have any questions real quick on some of the stuff that I went over? It's okay if you don't. I hope I'm not boring you. Sure.
I know you mentioned something about which feels like a lot of data on outcomes How are you able to address that with funders? Are they okay with that?
Great question, and I should clarify. So she had asked, she said, you don't collect hard data on some of the programs. It was just Healthier Living, the Chronic Disease Self-Management Program. And Lynnzy, is it okay if I just let you take, do you want to answer on that program?
What we do in terms of data is, oh, is it on?
Yeah.
Ooh, lovely. Hi. What we do in terms of data is we do participant demographic information, we rates, and one of the things we'll talk about is we track how people are referred into the program. In terms of the efficiency of the program and how it's delivered, there's about 20 years worth of research out of Stanford, and what we found is we were just duplicating what had already been done in terms of when we measured confidence levels and what people were getting out of the class. So now we're focusing the work that we're doing on how do we track things like referral systems and things. But we do still collect participant data. Yeah.
And just as a follow-up to that, too, with our other programs, all the other 6 programs, we definitely collect data. We have pre- and post-tests. We do senior fitness testing, their upper body strength, lower body strength, just their activities of daily living. And, yeah, we have a lot of questionnaires because our grant funders do want the numbers. So, and they actually look really great after all of our programs. So, which is hopefully telling us that they're doing a great job of actually working and impacting these the participants' lives. Am I okay on the time?
Yeah, you got a couple of minutes.
Okay. So real quick, I wanted to ask a question. How many of you in here are service coordinators or activity coordinators? Can you just raise your hand? I just would like a little bit of a view, okay? A lot of times coordinators will ask, well, how do we get involved? And you can contact Volunteers of America anytime. I have my business card up here and a flyer for you with all of our programs. But usually what we expect from our coordinators is to get a lot of information on the residents. They're the ones that know them best. We can't come in and say, oh, we want to do this program. Maybe they're a highly active younger group, maybe 60 to mid-60s. Maybe some of them are still working. Well, they probably wouldn't be interested in a fall prevention program because that's not really a concern at this point in their life. So maybe we could do the group exercise program. I talk to coordinators a lot and kind of wean which way should we go. Should we go with nutrition? Do you feel like people are going to want some nutrition education and they get to do all these different food samplings and get pedometers and TheraBands and things like that. So we talk to the coordinators. They're the ones that have all the wisdom about the residents, and we really like to kind of pick their brain on what works best. Lastly is how do we get residents to come to our programs or just participants to come in? And it's a little bit different. Usually for a first-time site, if we've never been there, we have scheduled like nutrition presentations where we can come in and they can actually see a face, they get to know us a little bit. I'll come and talk about physical activity and goal setting and all these different little topics with the residents. Then we'll say, how many of you would be interested in a program? And then we just start talking there. If we're revisiting, actually, let me go back. If it's a first-time site, too, we like to do a kickoff party. So this is where they can come in, they can get some information from us, ask all the questions they want. We want to make sure that they're getting into the right program. How is it going to benefit them? We want them to apply this to their lives, not just come and get a free prize, not just come and get a pedometer. So we really want them to grasp a hold of it and really take stuff with them as they age in place. And then I was going to talk a little bit about a lot of our participants are women, and a lot of times, and just in general, I think participants who are reluctant to come out of their rooms, they're just more isolated and don't want to really do anything. There could be a variety of reasons. I know some people had mentioned before that like if they wanted to join a fall prevention program, they're a little hesitant because what if they open up about their weakness, they have weak legs, their fear of becoming not independent anymore and being put into assisted living. We've heard that before from participants. So I think educating and having our coordinators and us, of course, put the information out there, just be really positive about it, and really applying it, making it so they can apply it to their lives and take information with them is the best way to retain them in the class. And usually our classes are anywhere from 10 to 20 people. And we have grant requirements too, so we can't go over certain numbers for certain classes. So, yeah. Lastly, a couple more pictures, then I'll be done. This is Bob and Vida. We had taught a program at their senior community site, and they loved the program so much and wanted to get trained, and after 6 years, they're still teaching the same program over at their facility. That's just me exercising with the group. And we serve amazing snacks. A lot of times participants have never had bruschetta or caprese salad, and we give them recipes so they can actually take it with them, and we modify it so if they are on a strict budget, they can still make a lot of the things that we bring to class, which is a nice benefit of us coming over and working with the residents. And that's all I had for now. So if you have any questions after, I'm more than open and happy to talk with you. Thank you.
Thanks so much, Ada. So I have the pleasure of introducing our two next co-presenters. Two for one. Lynnzy McIntosh and Renee Karl. So Lynnzy is the Senior Vice President at the Consortium for Older Adult Wellness in Colorado. She trained to be a chronic disease self-management program leader back in 2008 and joined that team later that year. She currently is the new Colorado State Collaborative Chair, and some people call that assignment herding cats. She's very good at herding cats, and maybe we can ask her a little bit. Feral cats, even. Maybe we can get her to elaborate on that. She is also part of the Consortium for Older Adult Wellness team working with the Department of Aging Living Well grant. That's a long, very challenging sentence. And a member of the Self-Management Alliance Goal Number 2 work group and Self-Management Learning Network. This is actually my second time seeing Lynnzy. She's really quite wonderful, and nice to see her again. She's actually one of the experts in this field, and we're really happy to have her. And she is joined today by Renee Karl, who is the Quality Initiatives Manager for the Colorado Community Health Network, which is Colorado's primary care association. Her responsibilities include coaching, facilitation, and leading the Colorado Community Health Network Patient-Centered Medical Home Initiative. She earned her MA in medical anthropology and can tell us a little bit about that probably, from the University of Wisconsin, and completed a fellowship in India researching development in women's health. So, welcome.
Yay! Hi, everybody. Thank you for sticking in here with us. I am now going to multitask and get us to our kickoff here. So what we wanted to do is talk just a little bit about what we are trying to do today is to share with you sort of some of the connections between public housing, community health centers, and evidence-based programs. And COA is very fortunate in that we have some wonderful partners, including, and it's going to go. Okay, hang on here. Nope, that's not going to happen. I'm going to play the video now, I guess.
My name is Erin Fearhagen. I'm a patient navigator here at Peak Vista Community Health Centers. Peak Vista decided to work with COA and work with Healthier Living Colorado to sponsor these. We are very interested in becoming a PCMH, which is patient-centered medical home. And we realized that we need our patients' buy-in if we are going to not necessarily eradicate these diseases, but make them more manageable.
Hi, I'm Dr. Karl. I'm a family practice doc, and I work at Peak Vista. Yeah, I see patients of all ages and patients with all types of medical conditions, a lot of chronic medical conditions. And what we're finding with patients that have chronic medical conditions is that there's a big opportunity for teaching and for self-management. There's opportunity for teaching patients how to problem solve because they have to deal with their day-to-day illness. Nowadays, with the chronic conditions such as hypertension, diabetes, the whole metabolic syndrome, I can throw all the drugs I want at that patient, but they're never going to get better unless they can take charge, and then they can actually have much more of an impact on their disease process than anything I can do.
Hi, I'm Karl Solomon-Smith, and I'm a medical case manager at Peak Vista. I've been working for Peak Vista 3 years now. We're going to be using this class for our patients that have chronic disease states, and one of our goals is to make sure that the patients know how to manage their own diseases, because our goal with these patients is to reduce their emergency room visits and reconnect them with their primary care provider here at Peak Vista as part of our care coordination team. And on that team are our patient navigator. We have RN case managers. We do home visits with the patients to talk about their chronic diseases, but I probably will be referring most of my patients to this class as they finish the case management process with me to further their ability to self-care. The case management process that I'm doing right now, we get patients referred to us through the Regional Collaborative Care Organization based on their overutilization of the emergency room. And that's how the medical case management patients are assigned. We have an RN case manager and myself will go out and do an assessment of the patient's needs. And the goal is to do a 3-month intensive case management period with them. But during that time, I will be self-referring patients to the classes that Erin and I will teach, because at the end of that intense case management, we want them to further their knowledge. And by taking this Healthier Living Colorado curriculum, Erin and I really feel like that they'll have a lot more tools to do that on their own.
There you go. Now let me explain why we showed you that video. The idea is that what we work together with here in Colorado is to bring classes to people where they are and where they live. And so we work with some of our wonderful partners at organizations like National Council on Aging who help us learn how to deliver this program better. And then we work with some of our community partners, such as Volunteers of America, to help deliver and reach folks within housing areas and within community centers and within senior centers. And then the part that this video talks about is the work that we're doing with community health centers. You know, what we found was that if people are isolated, if they have chronic conditions and if they're not doing well in their life, one of the places they still go is to their doctor. So it made sense to reach out to people where they were, and that could be the community health center. So I'm going to introduce, how do you like this multitasking? Is that not impressive? Okay, there we go. Now we have our slides up. So I want to introduce Renee Karl, who is with the Colorado Community Health Network and is really the person who helped us tie all these pieces together in terms of bringing together the community health centers, the public housing, and the people that need assistance. So, okay, Renee.
Hi, I am going to talk briefly about the work that we've been doing with community health centers in Colorado around patient-centered medical home and how that ties in to work with vulnerable populations, as well as the chronic disease self-management classes that Lynnzy has been so successful in bringing to our health centers. So just our intro of who we are again. Lynnzy is with the Consortium for Older Adult Wellness, and I'm with the state PCA for Colorado Community Health Network. And I am going to introduce patient-centered medical home. There's a lot of momentum around patient-centered medical home movements right now. HRSA at this point has a goal that all community health centers will be nationally recognized as a patient-centered medical home by 2015. Currently in Colorado, 59% of our health centers have national recognition as patient-centered medical homes. And we've talked about evidence-based programs, and patient-centered medical home is one evidence-based program for improving the quality of care and impacting health outcomes. A lot of the changes associated with this model show better disease outcomes, including continuity. Action planning can really reduce A1C for diabetic patients, and having medical assistants review records for care gaps results in improvements around a whole host of measures, including A1C, LDL, smoking cessation, and preventative measures. So patient-centered medical home, it's facilitated by registries, information technology, and then other means to make sure that patients get the care they need when they need it, where they need it. And that's where our partnerships with places like Volunteers of America and the Consortium for Older Adult Wellness and chronic disease self-management classes come in. So what does a patient-centered medical home look like? It really is a model where the patient is at the center of the healthcare and the system design. What has happened and what we've learned anecdotally in Colorado is that systems level change is really what provides sustained improvements in health outcomes. When we started this, what people were realizing is they get into rooms and have discussions about, why are our low-income patients not getting the preventative services they need? And discussions would tend to center around maybe health literacy or around, cultural barriers. And the reality is that the problem usually is not the patient. In fact, the problem is never the patient. The problem is the system. So patient-centered medical home is a way of making sure that the health system is designed to meet the needs of the patients. It's also a way of achieving sustained improvements in health outcomes. Another anecdote from Colorado is that when people started to look at specific health indicators, they felt like they were playing a game of whack-a-mole. So hemoglobin A1C and diabetic control, they would get that down and it would start working, and then they'd look at cervical cancer screenings, and that would go down. So they'd start a program to improve cervical cancer screenings, and then they'd look at their A1Cs, and their A1Cs and their diabetic patients would be out of control. So they felt that the best investment of resources was really looking at system change to improve health access and to ensure that patients have the tools that they need to manage their health care outside of the clinic. So patient-centered medical home works through a personal physician, having the patient be at the center of their care and actively involved as a partner in designing their care plans. A team approach where medical assistants, clinicians, community partners, and behavioral health all work together to provide care for the patient. And then having care coordination, and that's care coordination with specialists as well as community resources. Just without going too much into the weeds, because we would be here forever, we'll talk about NCQA briefly. This is the National Committee for Quality Assurance, and they provide recognition as patient-centered medical home. It's one of 3 bodies that does recognize patient-centered medical homes, and it's a big focus for, and NCQA is a major focus for the Center for Medicare Services right now. There are 6 must-pass elements, including access, data for population management, care management, self-management, referral tracking, and continuous quality improvement. I'll talk a little bit more about care management and self-management. So care management is really making sure chronic patients have the tools that they need in order to manage their care. And it involves implementing evidence-based guidelines, identifying your high-risk patients, medication management, like e-prescribing, and then comprehensive care management. There's a whole lot involved in comprehensive care management, and that's just a brief summary. But the key pieces are all patients should have a care plan. So they need to have a written care plan that indicates what they need to do in order to treat their disease. And at every visit, they should have a clinical summary that describes what happened in that visit and what their role is. Also, patient-centered medical home is really focused on high-risk and vulnerable patients. And this is where our partnerships and our discussion of public housing comes in. A high-risk patient is one who has comorbidities and is really at a high risk for hospital readmissions. And in order to be a patient-centered medical home, you have to provide those patients with additional care management. Also, we talk about vulnerable populations. And vulnerable populations are people who are not disadvantaged through necessarily their conditions, but through social structure. So this would be people who are in public housing, people who face other barriers to accessing care, and managing their chronic conditions that relate to their socioeconomic environment. And so self-management support for these patients is a key part of patient-centered medical home, and this is what we've been partnering on very closely, and the work we did with Peak Vista, as you saw in the video. So to support self-management, you should provide educational resources to 50% of patients. Use your electronic medical record to identify educational materials. And then the big one is developing and documenting self-management plans and goals with more than 50% of your chronic patients. And this is really key. In a Stanford University study, patients who had written action plans were 80% more likely to meet those goals than patients who did not. So having that written action plan really can improve health outcomes and patients' ability to meet those goals. Assessing ability and willingness to change, and then providing self-management tools, which would be blood pressure logs, glucose logs, food journals, anything that can help patients support themselves when they aren't in the clinic, and counseling patients to adopt healthy behaviors.
Can I say just a couple of things about the self-management work in terms of the NCQA piece? Ada talked about how important it is to have people in the class talk about what they want to do, what works for them, how it works. Part of what's happening with this whole transformation in healthcare that we're going through is we've moved from a system where the medical system is the gatekeeper. You know, our job is to decide as the medical system what you get, what you don't get. Our job as a patient is to go ask. And now what's happening is the whole shift is happening so that we're moving toward I, as a patient, am the center of my own care. And that care includes not only my healthcare team, not only the MA, the provider that I see, the people that give me prescriptions, but it includes being able to reach out into the community. So my system of health and care includes wellness, includes classes in exercise, includes better eating, includes safer housing, includes more inclusive activities and transportation within the neighborhood. So it becomes a patient-centered medical home. It becomes a person-centered community and a person-centered system for wellness and prevention and care. So the only problem with all that is that we can measure all sorts of things. We can measure A1C levels. We can measure how many times I go to the doctor. We can measure all those things. What we can't do, though, is make any changes until I, as the patient, do something different. We can measure my A1C level every day of the week, but if I am still eating the same way, exercising the same way, living the same way, nothing moves. So part of what self-management support is about within the NCQA, within the whole patient-centered medical home world, is about how does the health team support me as a person in making changes. So that's really the focus of what is self-management support. It then interacts with what's happening in the housing world, what's happening at the community health center, but it's all about supporting the change within the patient. And one of the nice ways to be able to hook those things together is to talk about the National Committee for Quality Assurance recognition program that the community health centers are all going through in order to become recognized as patient-centered medical homes. This is a way we can help connect the dots and bring into different areas like community health centers, public housing arenas, the classes to make it all work. So, self-management goals. You want me to talk about that?
Absolutely.
Okay. So self-management goals. How many of you know what a self-management goal is? Okay. How many of you know what a New Year's resolution is? Yeah. So frequently when people talk about a goal, they think of a New Year's resolution. And you all laughed when I said New Year's resolution. But when you talk with most people, and you talk with most medical providers, which is what Renee and I spend a lot of time doing, going to community health centers, we ask them, what's a self-management goal for a patient? And they'll say, well, lose weight, quit smoking, be healthy. That's a New Year's resolution. And how well did y'all do with your New Year's resolutions? Did you do well? No? You did. Okay, well, you're the one then that did well. What happens is we think of goals, these big overriding goals, as they're do or die. You either do them or you don't do them, and if you are not successful, you failed. What a self-management goal is about is taking that big overriding goal, I'm going to lose weight, I'm going to stop smoking, and breaking it down into something that's very doable and achievable so the patient, so I, as a client, so I can experience success and then build on that. So part of what is written into the guidelines is the idea of establishing with the patient what their role is in their care. So there's the overall, here's our treatment goal. Our treatment goal may be to manage your diabetes, to help manage your depression, for example. Then there's the parts the medical practice can do. Maybe it's medication, maybe it's tests, maybe it's a referral to a community-based program like an exercise program or a chronic disease self-management class. And then there's the piece that I get to decide. And what makes a self-management goal is that it has to be something that the patient wants to do. I have to want to do it. This is not what you tell me I should do. This is what I want to do. The medical assistant can play a key role in setting that intention up, can have that conversation. But we want the goal to be something that's small, doable, specific, something that requires a behavioral change, is time sensitive, and again, something that can be documented as part of the patient's care. So for example, my big goal may be I want to lose weight. But unless you're going to hand me a magic wand for this week, I'm going to have to do something to make that happen. So maybe what my self-management goal is that I am not going to drink soda this week. Or if that's too big a goal, maybe I'm going to skip soda for 3 days this week. That is something I can achieve, that is something doable, and that is something that can be documented, and then you can check back with people on how it works. Oh, here's your quiz. See, I know they're doing pre- and post-tests, but here's your quiz. So this one is easy. Which of the following is a good self-management goal? I'm going to run a marathon. Renee runs marathons, so that's actually doable for her. I'll lose 10 pounds. I will not drink soda on Tuesdays and Thursdays. Or I will go to the gym for 90 minutes every day for the next month. C. Anyone here think anything, a different one? Somebody asked us why D was not a good one. If I'm already going to the gym 4 days a week for an hour, and I want to up it, and so I want to set the goal of, okay, now I'm going 90 minutes every day, that's terrific. But if I haven't been in a gym in 3 years, and I set a goal for, I'm going to do it now, woohoo, 90 minutes. I'll do it once, I won't be able to walk for the next week, and then I'll never do it again, and I've now failed. And so what you want to do, again, is to help people set themselves up for success. And one of the things that we see very, very frequently when we do the classes in the community is how powerful the idea of small steps toward a goal can be. And that's the power of the chronic disease self-management programs. That's the power of even patient activation in general. That's the power of practice activation, taking a big goal like NCQA recognition and breaking it down into small steps. So here is part of what we do when we work within the community health centers. I went one too far. A click too far. Sounds like a book. We talk about what the practice, what the clinic, what their role is in self-management support. Self-management is one of those really nebulous things. No one really knows how to define it. There's a definition that the World Health Organization uses, but we tend to go with the one we explained earlier, which is self-management is what I do when I'm the 97% of the time when I'm not in a health clinic. And self-management support is what you all can do to help me make those changes. So who is responsible for supporting someone in their self-management? Feel free to holler out an answer. Who's responsible? Providers? Okay. Providers, definitely. We would argue that everyone in the practice can be a part of it and is partially responsible. To get real buy-in from any clinic or organization, we talk about self-management support is about putting the patient at the center. And that is something that is important from the front office, from the moment you check in at a clinic, all the way to the back office, and then all the way back to the front. One of the things we hear from clinics a lot is the providers don't have time. They don't have time to sit and spend a half an hour to find out why I want to go on a diet and to encourage me to take it slow and steady in small steps. We don't have that kind of time. But if someone at the front office can start the conversation, and then the medical assistant, as they're walking me back to the exam room, can say, well, how goes that goal you had of walking twice a week? Are you still doing that? Great, that's terrific. So what are you going to work on this time? Are you going to talk with your provider about maybe some changes in what you're eating? Or are you going to keep working on exercise goals? What do you think? That's a real positive interaction, and if you build those every step of the way in the interactions in the practice, that's how you build self-management support.
And just as a follow-up, self-management support is a huge culture change for clinics. It's a culture change for all of the staff having this coordinated model, and it's a big culture shift for patients who now have to come in and be partners in their care. And one thing we've heard, again, from health centers is that having the MAs take on this role has been effective in a lot of ways, both in managing workflow, but also the medical assistants can develop a really different relationship with the patients than what you necessarily see with a provider, because there isn't that power differential, and there tend to be very honest conversations that take place between the medical assistant and the patient prior to the visit.
Yes. I mean, when I go to the doctor, I learn a lot about what's going on in the MA's life. We talk about kids, the weather, jobs, life, and usually it's not very focused on the patient. We're just suggesting changing the conversations around just a little bit. So when we talk about this huge, big shift that has to take place, the shift has to not only take place with the patient, okay, now it's up to me. I am now responsible for fixing my own health. That's a huge shift, but there's also the shift within the practice. Your job is not to be the gatekeeper. Your job is to have the patient at the center and to set everything up in support of that patient. That's a huge shift. But there's also a shift that happens at the community-based organization level, where we have to be willing and able to understand what's happening with the patient, what's happening with our clients, what's happening within the medical world, so that we are able to support what's happening at the clinical level. So part of what we do toward that is to do this work with the clinics up front and with the community health centers and with our partners, so that we are all providing documentation and information for each other. We also have, out of that, come up with a process that we use in different variations. And I have a printout of this, a version of this. This is what we call the workflow process that we use, that we developed in coordination with a couple of the community health centers that we work with. And this includes the front office introducing the concept of self-management by even handing out a form when people check in. Part of what we're going to do today while you're here is, when you see your provider, they're going to talk with you about what it is you want to be working on. We're all a team, so there's a lot we can do to support you, but what is it you want to do? And we can give them a piece of paper that maybe doesn't have a lot of even words on it, that doesn't have to be at any given reading level. It can be something that is a nice, friendly, inviting form that has visuals of eating healthy foods, visuals of somebody walking or exercising, visuals of somebody smoking a cigarette with a nice little delete mark over it. It doesn't have to be anything that's high and mighty and confusing. Just very simple concepts of what is it you want to work toward. And sometimes patients will say no. And that's perfectly okay if they say no. I mean, the phrase self-management goal sounds a little bit overwhelming to begin with. So if you again use phrases that are more appropriate for the folks you're talking with, what is it that's important to you? I mean, we spend a lot of time explaining what is self-management to medical providers. So I think since we don't have 2 hours to explain it to everybody that you're going to see in a practice, you need to use words that go right to the heart of what you're talking about, which is how can we help you reach what you want to be doing in life. So we start with that information at the very front office. We do some training with the MAs around what is a good conversation to have in terms of self-management. We then encourage the MAs to actually complete the forms and to chart them. And Renee and CCHN have done a lot of work around how that charting takes place within the practice. You want to talk for a second about how that works or doesn't work?
Our goal is to have, the self-management goals as structured data. So it's entered into a data field that's searchable within the medical record. And then what happens is every month, the clinics will print out a registry of patients who have documented self-management goals and follow up with them on those goals, and then follow up with patients who don't have goals. And that follow-up is a really key part of effective self-management. And what it does is it also allows the health center to get in touch with patients who aren't able to make it into the clinic. So if you're not there for an appointment, you can still get a phone call from your medical assistant, from the clinic, saying, how are things going? How are things going with that goal? And that follow-up has just been a key part of getting patients engaged in self-management. Rather than getting your self-management goal at one appointment and then coming back 6 months later and you forget about it in between, the care plan goes in the back and you go through Wendy's and get a Frosty.
Super Frosty. Super Frosty. $2.99 on special. I'm just saying. I know about these things. Yes, and so we, then what happens is the clinician can then reference that conversation and can add to it. And, I will say that the next part is to us very vital, not mandatory, but very important to us, which is the patient gets a copy of their goal, and a referral is then made, if appropriate, to a community-based class in chronic disease self-management or any of the other programs that are out of Stanford. It may be a chronic pain program. It may be Tomando Control de su Salud, which is the Spanish translation, a cultural translation of the program. It may be a diabetes self-management program. There's a number of different opportunities. It may be a falls prevention program. It may be an exercise program. But those referrals are really critical. And then what happens is when those go to the community organization, we then track them. We track the referral. We provide feedback to the practice or the RICO, whoever it is that's referring people to us. We then are able to let them know whether the person has come to class. If they haven't come to class, we let them know why. And we hear things like, I don't have anything wrong with me. Okay, well, I'm on oxygen and I am in a wheelchair because of I can't feel my feet anymore, but my diabetes, I guess, is out of control. But I don't need a class. I don't need to learn any new things. I'm just fine. I mean, we live and work with our chronic conditions so much that we just don't even know they exist anymore. It amazes me how many people we see that come to class that do not know they still have high blood pressure. They have a diagnosis of hypertension, but they've been given a pill. So they don't have hypertension anymore because they take a pill for it. I don't have diabetes because I take a pill for it. Well, it amazes me that it takes us 6 weeks, 2.5 hours a week, for people to realize that what's going on with them is something chronic and is something that they can make choices about in an ongoing way that will help them feel better and better manage the other things that are going on, not only with whatever their diagnosis is, but in their life in general. What we see with the community health center folks is that their lives are complicated. They have a lot of different things going on. So as somebody was saying, I think it was Lieutenant Governor earlier, it isn't just a matter of managing your diabetes. It's managing your diabetes and where you're going to live and how you're going to get to work and how you're going to eat and what you're going to eat and how will you get the prescription. So all of those things can be worked on a piece at a time. And frequently it takes referrals to community-based organizations to help make that possible. Some of the goals that we see coming out of the classes are not what you would think. They are not necessarily the, I am going to go for a walk every day. I am going to eat organic vegetables. There are things like, I will get out of bed every day this week. If you're working with someone whose primary diagnosis is depression, getting out of bed is a reasonable goal. Some people have a goal, I will come to class next week. I will be here again. One of my favorite stories is about a provider we worked with here in Colorado who's, after one of his patients had gone through class, he said for the first time his patient came back to see him, and for the first time he was sober, and he had taken a shower, and he was wearing clean clothes. And he had never seen his patient like that before. And I said, well, did that change the quality of the interaction and conversation you had with your patient? Did that change the conversation? And he said, no, not really. But for the first time, there were two of us in the conversation. So, taking a shower may not seem like a big goal to have achieved if you measure it against running marathons. However, for this person, this was huge. And for this physician who now could have a conversation, this was very big. So what we do after we get those referrals is we keep the practice in the loop. The person then goes through the classes, and at the end of their time in the class, they write a letter back to their primary care provider at the community health center or wherever else, and they talk about what they have learned about managing their own chronic condition. And it is things like, I now realize I have asthma, and if I'm all stressed out, it gets worse. I now realize that I feel better if I get a little movement. And I know my doctor told me that arthritis would feel better if I moved, but I didn't believe him. But now I've seen it work. I feel better if I take deep breaths. If I take my medication on time, I feel better. And so in terms of care management, medication management is a huge issue. And Kaiser Permanente study says that 25% of us actually take our medications the way we're supposed to, meaning we actually fill them, we actually take them, we take them till they're gone, we don't share them. So if only 25% of us are doing that, that means 75% of us are not making the most of it. So part of what we include in this curriculum is how to talk with your physician, how to problem solve. If you're having problems with a medication, if those of you who work at community health centers, wouldn't you rather know your patient's not going to be taking the medication than to think they're going to be taking the medication and 3 months later when you see them again, nothing's happened? Better to know those things, and that comes from a conversation with the provider, and it also comes with a conversation with us learning how to better communicate and be okay saying those things to our provider. And then we go through all that again, and we just keep repeating. We repeat and repeat, and we repeat with the goal setting. Probably the worst thing that can happen is for me to go home and have this great action step in my mind, and you print it out at the practice and you give it to me, and I go home and I go back in my 2 months and I've lost 5 pounds and I'm proud of myself, and nobody says a thing. Nobody acknowledges it. Nobody talks about the goal I set last time. So again, it's a paradigm shift for the practice, it's a paradigm shift for the community and for the patient too. You want to talk a little bit about barriers? Okay. So we see several different kinds of barriers. And I just love this because we're moving mountains. See, we're in Colorado, you move mountains. Some barriers are real. Some barriers are perceived. So a real barrier. What would a real barrier be? Money. Money's a barrier. Money can be a barrier to housing. Money can be a barrier to care. Some of the barriers might also be time. How am I going to get there? I would love to go to a class, but it's 3 buses to get there and 5 buses to get home. Those are real barriers. Some barriers are perceived, and that might be something like a class in falls prevention is not for somebody like me. It's for those people. It's for those people that live in that neighborhood. It's not for me. A chronic disease self-management program is not for me. A class is not for me. There won't be people like me in there. It's not for me. Part of the reason we started doing the community classes not only in the housing world, like with the VOA facilities, but within community centers and at the community health centers and in practices after hours, is that was someplace people felt comfortable going. We do a program that we've done with Salud, which is a community health center here in Colorado, that's been running for years now with the YMCA, and people initially said, that's not for us. That just isn't for us. And part of it was the time involved. They were trying to run classes on a fairly traditional schedule at the Y. They had a day class, they had an evening class. Well, that didn't work for the population they were serving. So what happened was they ended up setting the class at 3 o'clock in the afternoon on a Saturday. Now, I don't know about your life, but there is no way you would get me into a classroom on a Saturday afternoon at 3 o'clock. That just doesn't make sense to me. But to them, it filled the class because that worked with the barriers of I don't have the car during the week. I am watching the kids during the week. Sunday and Saturday morning, we have church activities. Wednesday night, we have church activities. But Saturday afternoon, that's my free time. That's before things start on Saturday night. That's after things are over in the morning. Saturday afternoon works. They've been doing those classes now for years with great success because it works with what works for the community. And they've been able to work with people by having guides walk them through the process so that people realize that it really is people like them that are in the class, whatever the them is that they're perceiving. So how do you tell which is a real barrier and which is a perceived barrier? They're all real. They're all real. If you think something isn't going to work for you, it doesn't. You are totally correct. So what we work with the practices a lot and what we work with our staffs a lot about is you never know when someone's going to be ready. You never know until you have a conversation about what the barriers are, how you might help somebody get through it, around it, over it. And if the time is not right to work with it now, it may be later. So we end up with referrals that we get. Not everybody goes into the next available class. We've worked with people that it's taken a year for us to get them to come into a class. We're happy to do that because you never know on that patient activation scale when they are going to be ready to do something, when there will be that opportunity. So we're there when it happens.
Another piece of this is often health centers are not always comfortable asking and documenting barriers. One reason for this is because they get the barriers and then they just feel helpless to fix them. You know, What do you do if your patient can't afford medication? What do you do if your patient doesn't have transportation? And one way we support the health centers in this is we really try to help them develop community partnerships. So helping them create a resource list, making sure that everybody in the health center knows what the resources are and knows how to make those referrals, and having strong ties to other organizations. So from the patient perspective, really knowing what the barriers are and having your health staff address both all of your barriers. And then from the clinic perspective, having a way to address those barriers when a patient brings them up is really important.
One of the skills that gets taught in the class is a skill called problem solving, which is one of those things we love, and we use it around the office a lot, which involves just generating every idea, good, bad, or indifferent, you can come up with, and then picking one to try. And if that doesn't work, you try something else. And that's one of the skills that we hear back from participants again and again and again, the idea of planning an action plan, a small, manageable goal, and then how to problem solve, and how to problem solve with your friends and family. Those are skills that can be translated into everything, not just healthcare. So engaging the patient. How are we doing time-wise?
You're okay.
Okay. So when we talk about engaging people in the process, we talk about, again, how do you approach a topic that's hard to talk about in a way that is appropriate and non-judgmental and lets people actually talk to you and you listen. So, for example, you want to lose weight. The next line should not be, well, thank goodness, because you need it. That is not a good next line. So you want to open up the conversation with something like, so you want to lose weight. So exercising more is that's a great goal. And then you want to maybe move into a tougher one. Is stopping smoking something you've thought much about? How many of you work with people you would like to see them do something different in their life? How many of you live with some of those people you would like to see do something different in their life? Well, you know how well it works to say, you need to do this. I want you to do this. That didn't work so well. So having something that engages in the conversation is very, very helpful. Do you want to do a role play? Do we have time? Yeah, we do. Okay. Are we going to do our favorite one? Mm-hmm. Okay.
So just to introduce, one of the things we do with practices is a lot of role-playing exercises. And the way that works is what we'll do is we will go in and we'll demo a role-playing exercise and then break the care teams into groups and have them practice action planning with with each other, demonstrating how they can do that with the patients. And then occasionally what we've done is we've actually videotaped interactions, played them back for the whole group, and had everybody commented on how well that works, what could have been better, what could have been done differently. And that's a way of developing motivational interviewing skills and getting people comfortable having these conversations. So we always start with the, really bad one, because after that, nobody can be worse.
Are you saying I'm a bad MA? Yes, I will be a bad MA. This is like one of my favorite things to do. Okay, so you now have heard what self-management is and self-management goals. So I'm the MA, the medical assistant, and I come in and I say, okay, so Renee, part of what we're going to do before your provider gets here is we're going to talk, we need to come up with what you want to do for your self-management goal.
What's a self-management?
Well, self-management goal is it's something I write down in the chart that you want to do. It could be like anything. Most people want to be on a diet. They want to lose weight. So that would be a self-management goal, losing weight.
Do I really need to lose weight?
I don't know anybody that doesn't want to lose weight. We all struggle with it. And, I've been trying that thing where you only eat vegetables every other day and then you eat fruit 3 times a week. But anyway, everybody needs to do something. So I'll just write that down, that you're gonna work on weight. That's gonna be, and then I can put that in the chart. Okay? How do you want to lose weight?
I'm not sure that I need to lose weight.
Well, that really is a conversation between you and the doctor. I can't get into that. But what I will do is I'll just write down that that's going to be your goal. And, there's a lot of different ways to lose weight. My sister-in-law, she's been doing Weight Watchers, and that works really well. Should I just say maybe you'll look at Weight Watchers, or you don't know yet how you want to do it?
Sure.
Okay, and then I'm sure that we can give you like a diet sheet that'll tell you everything you need to know about that. Okay, well, terrific. So we have your goal. You're going to lose weight, and the doctor will be in to talk to you in a few minutes. Thanks. So how effective was that? Yeah. Now, first of all, you can look at this and see probably we don't need to put Renee on a diet. But honestly, what did Renee learn about what the importance of a self-management goal is? Did Renee have any idea what a self-management? Did the MA have any idea what they were asking for, actually? And then how happy is Renee going to be when she's with the provider and the provider is looking at the notes? I mean, it makes no sense. The really hard part is next time Renee comes to talk about self-management goals, she's going to remember what an uncomfortable experience this was rather than a positive experience. And what you want it to be is a positive experience, something that demonstrates that the clinic, the practice is on the same page as the patient so that then you can work together. You want to try a good one? You want to do a quick? Okay. So, Renee, part of what we're going to do, now I'm going to be a good MA. So part of what we're going to do, Renee, is talk a little bit about what it is you want to do around your health. Is there something you've been thinking of in all these different areas of diet, exercise, nutrition, stress management? Is there something you've wanted to work on?
I guess I've been thinking about maybe being more active or some kind of exercise or something.
Well, exercising, being more active is a great, great goal. And so what we want to talk a little bit about is what you want to do to get started. How much are you doing now?
Nothing.
Nothing. Okay. So the plan is to start doing something small that you really want to do and then build on it. So is there something that you really enjoy doing?
Maybe gardening?
Gardening. That's a great way to get outside and get some movement. Okay, so if you were going to garden, and now's a great time of year to do that, how would you set that up? How often would you like to do that?
I don't know. I don't really have anything set up.
You don't have anything set up? Okay. Well, how about if we make a plan that between today, when we first are talking about this, and when you come back next week, because we're going to go over your lab work, that maybe in that week you think about how you might like to get started getting some activity around gardening. Would that work?
Yeah, I want to garden. I just don't really have space for it.
Okay.
So maybe a community garden.
A community garden would be a great idea. Do you know a community garden near you?
No.
Well, I have a resource list, and we can put you in touch with some folks that can help you find one that's close to you. So maybe what we do is the goal for this week is to help investigate where you might go and do some gardening. And then next time you're here, we'll talk about how to maybe do some planning around supporting you so that you can go out and do some gardening.
Oh, that sounds good.
Great. Okay. And on a scale of 1 to 10, 1 being I'm not going to do this, and 10 being I am absolutely going to do this, how confident do you feel you could investigate this a little bit?
I think I'm an 8.
Well, that's terrific. Okay, I'm going to write that down. Provider will be in a couple of minutes, and then we'll talk next time I see you about the gardening.
Okay, thank
Great.
you.
Thanks. So, aren't we brilliant? So, thank you. So, that's something she wants to do, something that's doable, something that's achievable, something she's taking some ownership with. And now the next time she comes into the practice, we'll acknowledge her for that, see how it's going, and talk about how what she wants to do with gardening fits in with how we're going to manage her chronic condition, no matter what it is. So that's a little bit of the brainstorming activity. We're going to turn it back over to Mary now and our pals at the NCOA. Just so you know, we have a handout. We have some information. We love talking about this stuff, obviously. So if there's any questions or any more information we can give you, let us know.
Thank you very much.
Thank you, and I hope we've really piqued your interest in evidence-based programs and the chronic disease self-management program. And if we have, one of the thoughts you may have is, how do I find out what's going on in my state? How do I find out who to contact to find out more information about these programs? And there are programs going on in a number of states. I certainly can't stand here and tell you who to contact in each state, but I can tell you that you can get in touch with the National Council on Aging, which is a service and advocacy organization that's based in Washington, D.C. There are 2 areas of focus for the National Council on Aging. One of those is economic security, and the other is healthy aging. The National Council on Aging is the resource center right now for evidence-based programs and for the chronic disease self-management program. So if you're interested in finding out what's happening in your state and who to get in touch with, you can get in touch with me, and I have some cards up here, and I can tell you who to contact in your state. The other thing I'd like to stress is we've talked a lot about public housing, we've talked about the federally qualified health centers. There's another leg to this whole effort, and that's the community-based organizations, because quite often it's a community-based organization that is actually leading chronic disease self-management programs and other evidence-based programs. The area agencies on aging have been very active in this, and you probably all are aware of your area agencies on aging. Every state has them, and they have a state unit on aging at the state level. The departments of public health have been quite active in this as well, because you've heard from our presenters today about the importance in terms of arthritis and diabetes and so many chronic conditions of having self-management programs. So the departments of public health are very involved in these as well. So if you are interested, you can contact the National Council on Aging, you can contact your state unit on aging, you can contact your State Department of Public Health, and they can probably put you in touch with some community-based organizations that can give you the information about where and how to find these programs. I just want to tell you about a couple of programs that are going on in other parts of the nation. Another thing we've talked so much about this morning is the partnerships that are around and the importance of partnerships, because no one can do everything on their own. A public housing site may have the room, and they've got those residents who have chronic conditions and who could benefit from this. They may not have the personnel to actually run the programs, however, and they may not know where to get the programs. They may not even know the programs exist. So some of the great partnerships that are going on around the nation are between public housing, between those area agencies on aging, between programs like the YMCA, sometimes hospitals, federally qualified health centers. So each one brings something different to the table. As I said, public housing may bring the site, and they may bring the residents who would benefit from it. The State Unit on Aging could bring the expertise in terms of the training, who to go to for these programs, and how to get in touch with those agencies. So it is a partnership. And I'd like to end with just a couple of stories about what's happening in several parts of the country. One is in Texas, with the Bexar Area Agency on Aging, and they are offering chronic disease self-management, diabetes self-management in both English and Spanish, and also a matter of balance in public housing sites. The program is offered in 33 public housing sites, and it works very closely with the case managers at those sites and the resident service coordinators. And as Ada has pointed out, nobody knows better than those staff who of the residents could benefit from something like this. They are the linchpin between the programs and those people who could really benefit. So the case managers and the resident services directors or managers are those people who are saying, I've got several people in my housing site who have fallen recently, and I'd really like to offer a matter of balance. Or I've got a number of people in our housing site who have chronic conditions, and I'd love to see us offer the chronic disease self-management program. In Texas, with the Bexar Area Agency on Aging, this program has been so successful that some of the public housing residencies are thinking that they might make it mandatory for new residents coming in to take a self-management class. Another place that has a very good partnership is in Vermont. And Vermont is offering evidence-based programs for their supports and services at home program. And that's part of the Medicare Advanced Primary Care Practice Demonstration Project. It's part of payment reform. There's a wellness nurse and a case manager who's assigned to every 100 people who are Medicare beneficiaries. And the system is organized around low-income public housing sites. And the wellness nurse and the case manager help determine which program should be offered in which housing site. Because again, they are ones that are in that community, they know what the needs are, they know what the residents may be interested in learning. And this program started with a pilot for 65 participants in the town of Burlington who live in public housing. Many of those residents were at least 80 years or older, and a number of them were on 5 medications or more. They had a high usage for emergency departments and inpatient care, and they were socially isolated. So through the supports and services at home program, they began with the case manager and with the wellness nurse to do assessments and determine which classes should be offered. And after the classes were offered, there was a significant drop in the use of the emergency department. There's a drop in the use of drop in the length of inpatient stays, and there was a drop in the amount of time that was spent in transitional housing, such as in nursing homes, before coming back to the community. Implementing the programs has also brought new resources into the housing sites, because now they're connecting with hospitals, with federally qualified health centers, and with others that can bring resources into the community. So I would just like to end by saying again that partnerships are so invaluable. You've seen a great example of partnerships here in Colorado, and there are partnerships that you can form if you're interested in pursuing this further. At this point, I'd like to close and ask if there are any other questions, if people had something they wanted to ask before and they didn't get a chance to.
Please. Right, resource sharing. Right.
My committee, we do an annual survey project called Flyer Information Survey Project, not target population, public housing residents only. And we go out and we fly at 10,000 occupied units in fancy development. And then we take 10% of that and do a one-on-one health survey with them. And we take that information and we get back.
I don't want to interrupt, but can people hear what you're saying? Because there are a couple of microphones. You might want to pick one up. I have a feeling the people in the back may not be able to hear. And I think you're making some good points.
Test.
Hi, my name is Eugenia Smith, and I am the chairperson for the Community Committee for Health Promotion in Boston, Massachusetts, out of Boston University. And what I was saying to the panel, and excuse my back, but these are my comrades here, so I'm going to back up so that I really don't have my back to you. I think it's important that when there's presentations like this, that the people in the audience have a voice, and that voice should be heard during these presentations, because while they may have a lot of valuable information, I might want to hear something about what you're doing in your state and the programs that you're running and how you're reaching out to public housing residents. And you may want to hear something that I'm doing in my state as far as reaching out to public housing residents. So I'm going to take this time, and if anyone has to go off, that's perfectly fine, but I just want to let you know that in Massachusetts, particularly in Boston, my target population is totally public housing residents in family developments. And annually we conduct a survey, but we start the survey off by sending out a flyer to 10,000 units, occupied units, which means we work with the housing authority because we can't get access into all of the hallways. Plus we need to know if it's safe at a particular time to be in a development. If they've got some issues going on, I wouldn't want to send one of my members out there and it's not safe. So we work closely with the housing department, because they are one of our partners. And we flyer these units, and then our members go back and they survey one-on-one with the residents, 10% of that 10,000. So we gather 1,000 surveys, and I actually have a copy of the last surveys we've done for the last 4 years and those flyers if anyone wants to take a look at them. I only brought about 10 copies. We then gather that information because a lot of folks go in, and they go into public housing especially because it's an audience that's not going anywhere. So they have their total attention. What we do is we make sure whatever information that we take out of public housing, we bring it back and say, you took your time to answer our survey, and this is what we did with that information. And we bring back a layman's report, something that they will understand, because I can't give them the data analysis, because some of the times I don't understand the data analysis that comes back. So we do a layman's term, and we go back into the developments, and we say, what's a good time for you? And where should I go? Should I come to a dance performance you're having? Should I come to your monthly meeting? How do you want me to come back and present this information to the community? And we go back and we do that, and we also leave the information with the managers. We allow public housing to put 2 questions on the survey. We allow our health commission to put 2 questions on the survey. And then we ask anyone in the community that is also serving if they're doing something and they would like us to put a question on the survey for them.
Maybe if there's a group that's interested that wants to hear more of the specifics, would you mind hosting a little round?
Yes, okay, so that's what I have, and I'll turn it back over to them.
Thank you. Thanks so much. So anyone that has questions for our panelists? Questions? So please, Henry.
Taken in my impression that most of your, it appears that most of your interventions were with seniors. Was that a correct perception when you talked about your Volunteer America experience and you talked about your managed care goals, self-management goals? I didn't hear a lot about the young mom living in public housing and the approach to get their care managed.
Very good question. Thank you. Because of who we're talking with today, with the National Council on Aging and Volunteers of America, we talked more about what we're doing in that 60-plus world or 18 with disability world. We have some wonderful projects that are going on. We're working with Teller County, which is their public health department. Their community health center is actually located in the neighborhood school. They are a frontier version and a sister clinic of Pikes Peak that you saw the little video on. That program is hosting classes actually at the elementary school / clinic. And what they're seeing is a very young population, exactly as you would expect, and they are single moms. We have a program going in Aurora, Colorado that is connected to an obesity prevention program for kids. So the kids go to soccer, and while the kids are having soccer and healthy snacks, the moms and the grandmoms are in a chronic disease self-management class. Then they all get together and have snacks together. So the kids are making the snacks, and then the moms are getting to have them too. So there are some wonderful programs that are going on around that as well.
Okay, we have another. I think we only have time for 2 questions, unfortunately. Let me turn it over to you, Ann.
My name is Ann Freeman. I'm the Vice President of North Lincoln Mid-Rise, and I would like to know if you have for HIV, full-bloom AIDS
programs
here in Colorado for your to help your community on things on HIV.
We actually have the license to do what's called the Positive Self-Management Program, which is the chronic disease self-management program specifically for the HIV/AIDS community. We have it available. Part of the sad news is that the funding got caught up in the sequester. So right now, we don't have that particular program running, but what we do have available is the chronic disease self-management program that works very well, and the data says it works very well in terms of viewing, because the strength of the program comes from multiple different chronic conditions coming together and sharing what it's like to deal with the emotions and the changes and the fatigue and the symptoms, et cetera, et cetera. So while there are some very specific things that are in that positive self-management program that unfortunately we don't have the funding to do right now, while we're waiting for the funding, we are doing the other program.
Wonderful.
Why I'm asking is because certain things that need to be taken care of with some of these young kids that need help with their HIV because they don't quite understand it, and we need to go and talk to other people in classes, school, and high school and grade school.
I totally agree.
Yes.
And the Colorado Department of Public Health and the Environment has some wonderful programs that are working specifically on exactly that, with not only within the schools, but with people with recent diagnoses and with all different parts of the state, so that there's a different program for rural regions as there is for the inner city areas. And so the Colorado Department of Public Health and the Environment has a lot going on in exactly that kind of education.
Wonderful. I'm hoping that you all might agree to stay just a couple of minutes later if people have personal questions they might want to ask you guys. Sure. Okay, please.
Hi. First a comment, or not a comment, but just to say thank you. I thought this was an excellent presentation. It was very informative and very practical, and I enjoyed that as well. One of the things just a quick question is, do you have the slides available or print out? Because some of the slides I thought it was very informative. as far as the NCQA and how about the self-management, and that would be very practical for me to take back home with me.
We will make the slides available on the website, and we'll let people know.
And we have handouts for you that have some contact information, so if you want to get in touch with us.
Wonderful. Okay, thank you so much. This was a wonderful presentation. Thank you all.
Thank you. Thank you. Thank you.
Hello. We do have a few handouts here if you want to come up to the front table. If you didn't get a handout, we'll also make sure these are available online.